Good evening, ladies and gentlemen. Welcome to another interesting live webinar. And this time it is Managing Follicular Lymphoma in 2022. We are extremely grateful to our program director, none other than Professor Dr. M.B. Agarwal, sir, who has roped in some wonderful clinicians, academicians ever since COVID started. And this is another important occasion. We all know, sir, very, very well. Professor Dr. M.B. Agarwal, sir, is President, Mumbai Hematology Group, Professor and Head Department of Hematology at Bombay Hospital, and sir is also consulted at Leelavati Hospital and Bridge Candy Hospital. But for us, sir is teacher of teachers, and country is fortunate enough to have him as he brings in so many stalwarts, clinicians, and also nurtures all the young hematologists of the country. No wonder, sir, you have been awarded the Inspiring Hematologist of India by Economics Times. May I request you, sir, to welcome everyone and also introduce the speaker. Over to you, sir.
Thank you, Dr. Manoj, for those kind words. Good evening to one and all from India, and good morning and good afternoon if you are from the rest of the world. We have over 400 delegates who have registered from 27 countries for this wonderful webinar that we are going to have in few moments. You are all eager to listen to our guest speaker, Dr. Nathan Fowler from MD Anderson. He is going to speak to us on managing follicular lymphoma in 2022. This webinar is brought to you by Mumbai Hematology Group. It is supported by INTAS and managed by Perfect Square. I thank Dr. Manoj Kumar and his team from INTAS for supporting our academic activities, Mr. Yash Kalpesh and the team from Perfect Square for their flawless management, Executive Committee of Mumbai Hematology Group, our guest speaker today, Dr. Nathan Fowler, all our discussants who are themselves eminent hematologists, medical oncologists from India, and you participants for sparing your Saturday evening, afternoon, or morning. This is our website, www.mhgindia.com. There is no password. All our future academic activities, you can visit this site and register. Tomorrow morning, that is Sunday morning, 4th December at 11:30 a.m. IST, we have Dr. Gaurav Prakash from PGI Chandigarh speaking to us on late effects of chemotherapeutic agents in hemato-oncology. Just briefly to introduce our discussants this evening, and we have very important persons from all over India, and they are alphabetically put up over here. I'll just narrate their names. Dr. Aditya Jandial from Chandigarh, Dr. Akanksha Garg from Jodhpur, Dr. Alok Shetty from Mumbai, Dr. Amarnath Polisetti from Vijayawada, Dr. Ankit Agarwal from Udaipur, Dr. Ankit Rayani from Ahmedabad, Dr. Archit Joshi from Vadodara, Dr. Chirasri Sanyal from Kolkata, Dr. Javid Rasool from Srinagar, Dr. Kripa Bajaj from Hyderabad, Dr. Mohammad Rizwan Sheikh from Delhi, Dr. Prasanta Bhatt from Mangaluru, Dr. Rajani Priya Yedla from Vishakhapatnam, Dr. Riya Balikar from Nagpur, Dr. Sachin Jain from Udaipur, Dr. Sarthak Vadera from Chandigarh, Dr. Sukriti Gupta from Delhi, Dr. Tribikram Panda from Gurgaon, Dr. Tufan Dolai from Kolkata, Dr. Vishwadeep Khushbu from Nagpur. And now it's my proud privilege to introduce our guest speaker who requires no introduction at all. He was our guest a couple of years ago in Mumbai, and you all enjoyed a great time with him, not only on academics, even on the personal front. He's also done webinars for us, and today he's back with us. I'm extremely grateful to him for sparing his valuable time to educate people on this side of the world. He's Professor of Medicine, Department of Lymphoma and Myeloma, Division of Cancer Medicine at the prestigious University of Texas MD Anderson Cancer Center, Houston. He received his MD and completed his residency at the University of Texas before completing a clinical fellowship in hematology oncology at Georgetown University, where he was a chief fellow. His interest in immunomodulatory agents began during his hematology oncology fellowship at George University Hospital, where he helped develop some of the first protocols to use lenalidomide in chronic lymphocytic leukemia. His focus at MD Anderson has been the development of novel approaches for lymphoma, where he led the clinical and the translational research program in lymphoma for 10 years, resulting in the discovery and approval of several immunomodulatory and targeted new drugs now used in practice worldwide. He also serves as the chairman of several phase 1 and investigator-initiated phase 2 trials for patients with non-Hodgkin lymphoma. He has also written several books and chapters about the treatment of low-grade lymphomas and is a regular speaker at international meetings regarding the development of new drugs in lymphoma. We invite him to give his lecture this evening on managing follicular lymphoma in 2022. Over to you, sir.
Thank you. That's a very kind introduction, Dr. Agarwal. Hopefully I can live up to that. So yeah, it's really wonderful to have the opportunity to talk to everyone, and I hope everyone's doing well. No one has COVID, and I wish this was in person, but maybe next time when this world is a little calmer, I'll get the opportunity to visit. I will start with, actually, let me share screen. Okay, can you see my screen?
Yes, sir.
Yes, let me just make this full screen. Okay, how's that?
Not yet, sir. Now, yes, perfect.
Okay, great. So please, and Dr. Agarwal, if you let me, my slides don't advance, sometimes I'll keep talking, but just tell me, tell me to stop sometime if there's a delay. So there's been some changes, actually quite a few changes in the last five years or so for the treatment of indolent lymphoma, specifically follicular. And so I kind of was, with this, I'll summarize some of the, I'm just going to go over some of the standard of care, but also summarize some of the recent changes. I didn't talk a lot about kind of early phase trials here, but I think there's plenty of else things to bring up, because the field is definitely changing. And the good news is that we've seen the survival of patients with follicular lymphoma increase dramatically in the last 10 years. In fact, several studies suggest that most patients who are diagnosed with follicular actually won't die of their disease, which is definitely kind of a different story than we were telling patients in like 1990s and even early 2000s. Now, again, I think I'm speaking to a lot of very educated people, so I won't do a lot of slides about biology. I just have a couple things. I think we all understand that follicular lymphoma is obviously a B-cell cancer. It comes from this initial hallmark mutation called BCL2. Now, the interesting thing is that BCL2, although it's present in follicular, and probably 100%, we can detect it about 85%, but because we're looking at different probes. But despite that, there are more mutations required to actually develop the disease. Around 25, maybe 30% of us will develop BCL2 mutations in our lifetime, but obviously 30% of the population does not develop follicular lymphoma. What we believe happens is that there are additional mutations occur as these B cells, these early B cells, are going through the germinal center, and those mutations, unfortunately, can be different in different people. They're probably epigenetic mutations. I'll show you a slide, things like CREB-BP, EZH2, which then lead to additional survival advantage and eventually develop a follicular lymphoma. Now, as I mentioned, one of the I think difficult things about studying this disease is that the mutational profile is extremely heterogeneous. This is just some data looking at patients with follicular, which is in the blue here, and red, which is at a later time point. And you can see that there are very few dominant mutations. Most of these mutations are occurring in around 20% of people, and they cross the spectrum of different types of functional mutations. And not only that, but as the disease progresses, these mutations accumulate, like we see in a lot of cancers. This is a study that was done by my colleague Michael Green when he was at Stanford. And here what we're looking at is 3 different time points. The green is the first biopsy, red is a second biopsy, and a third here is the third biopsy point. The size of this bubble represents the number of mutations that they found in the tumor. And you can see that these numbers are increasing, and there's also a split where there are several subclones that develop. And by the time these patients develop, or I should say have a kind of a third relapse, there are, again, many different subclones, but not only that, the subclones are made up of many different types of mutations. And again, this has made it traditionally very difficult to develop any single targeted therapy for follicular, again, because the resistance patterns are not only different in different patients, but even within a tumor, there are probably several subclones that have different profiles. Now, the good news is, there are some common mutations. We see, again, the MANCREB BP and these early biopsies are found in the majority, but there are several others, things like EZH2, KMT2D, and others that are quite common. But the punchline here is, though, in practice, the disease behaves very differently, and we know this, that you can have a patient that presents, can have spontaneous remission or even disease that does not progress for 10 years. But you also can see a patient without transformation that can develop rapidly progressive disease, progress after R-CHOP in 2 years, and can also do quite poorly and become resistant, within 3 to 5 years. And today we don't really have a good way outside of, and actually we don't have a good way to determine who of those patients that are going to do poorly. We've used Flippy and the IPI and whatnot, but generally they are not good at predicting the long-term outcome of an individual within a cohort. So I'll talk again about I'll flip and start talking about some of the ways we've developed drugs to target this very heterogeneous disease. The good news is that, again, over the last 20 years or so, we've begun to realize that follicular lymphoma is very dependent on signaling from the microenvironment. I think in solid tumors, we also see a lot of this now in papers, but lymphoma was one of the first models where we really began to understand that the function of the background T cells, dendritic cells, even the normal B cells can have a profound impact on survival. Follicular lymphoma, as you probably know, it's one of the few cancers that we really can't culture outside of a tumor. In fact, they're almost, in fact, I don't think there are any really good follicular lymphoma cell lines, because again, these population of cells can't exist without this environment of what we like to call nurse cells that are providing, again, co-survival signals that keep it alive. And although this may seem a little bit scary, trying to kill the cell, the good news is that targeting knowing that the microenvironment is so critical for the survival of these follicular lymphomas, it provides a wonderful target for therapy. So I will switch, and I'm going to talk now the way I've broken my lecture up, we'll talk about kind of treating patients with, at diagnosis, first-line therapy, and then go into kind of later lines of treatment, and eventually I'll talk to you a little bit, just a couple slides about transformation. So as I mentioned, with follicular lymphoma, when the first time you see a patient in clinic, I think one of the first decisions is to understand if the patient needs treatment at all. About 20-25% of patients will present with low volume disease and they're asymptomatic. Now, the field today is really focused on using watch and wait for these patients. And this is based upon several randomized trials, actually a couple randomized trials. These are old trials, probably 20 years ago now, that looked at the use of either chemotherapy or observation in patients that had low volume disease who are asymptomatic. And probably the one we all know the most was out of Britain by this Dr. Ardeshna. And interestingly, they found that the survival was actually longer in patients who did not receive treatment compared to patients who were treated immediately with chemotherapy. Now, the big argument here is this is not very good chemotherapy for follicular lymphoma. They all got chlorambucil in the treatment arm. But there were subsequent studies also done by Ardeshna where they used single agent rituximab. And in those studies, there was also no clear benefit of intervening early, at least with rituximab, in these patients who are low volume asymptomatic disease. Now, and I say this is the way the field thinks today, it's because we have not really done any other trials since then to look at these asymptomatic patients. There was the RESORT trial, but we don't know what it means to intervene with these patients with, for example, something like lenalidomide, potentially with other targeted drugs. But at least today, when I give this lecture to the fellows, I think that the standard of care in patients who have low volume asymptomatic disease is to do watch and wait. So you can imagine that the next question is, okay, when you're watch and wait, when do you decide to start therapy? And this is, again, a bit controversial. I often kind of tell my students that the trick is not to start treatment when they become symptomatic, but just before they become symptomatic. We don't want to wait till they develop kidney failure. So in my own practice, when patients develop nodes that are either doubling in size in 6 months, if they have nodes that are more than 5 centimeters, or if they have some symptom from disease, and that can be B symptoms, night sweats, fever, pain from the disease, for example, a large lymph node that is causing pain, or if they're anemic or thrombocytopenic, then I start treatment. So again, bulky disease, symptoms, rapid doubling time, or cytopenias, then I kind of start discussing therapy. Now, I wanted to kind of talk about how is treatment evolved. Now, when a patient becomes symptomatic, in the past, and I say, up till the 1940s until about the mid 1990s, we used either single agent chemotherapy or combinations of chemotherapy. And I think the most common ones were CVP, a fludarabine-based regimen like the ones that were developed at Anderson from 20 years ago, or combinations like CHOP, which included anthracyclines. But in the 1990s, we saw a dramatic change. And for the first time, we had a drug approved that actually changed overall survival in follicular lymphoma, and that was rituximab. Not long thereafter, we had radioimmunotherapy. This was approved in the United States for relapse disease. And then hold on, let me move this out of the way. Sorry, my own screen is blocking my view. In the late 2000s, or I should say 2008, 2009, we saw bendamustine and rituximab, which entered the market and rapidly became a very common regimen for patients that had untreated symptomatic or bulky follicular lymphoma. Now, I color-coded these, and I'll show you how some of the rest of the therapies have emerged. But it's interesting. We now have, in the United States, probably about 10 different regimens that are approved in the front line of relapse, and it's very different adoption. I put the ones in green here that I think are really, say, not controversial, but there are several additional regimens that have since been approved that, hold on a second, I'll show you, that, are used somewhat. And I mean, for example, maintenance rituximab, and I'll talk to you a little bit about that, has variable adoption across the US, I think a little more common in Europe. We also saw obinutuzumab approved in the frontline and the relapse setting, but in the United States, again, it's not, it's probably 50-50 how often this is used. PI3 kinase inhibitors were introduced, but recently have been taken off of the market. R squared has been, I'll show you some data about R squared in frontline and relapse. Frontline R squared is, again, variable with its use across the United States. There's still a lot of controversy around whether that should be the standard frontline. We have EZH2, which is now entering into the market, and I think it's actually a great drug. And now I'll show you, we recently saw introduction of CAR T cells for treatment of follicular, and those look really promising, especially in patients that are in their third line of therapy. But as I mentioned earlier, bendamustine and rituximab, I think, or bendamustine added to rituximab was one of the first kind of changes in frontline therapy outside of rituximab. And that was based on, this trial. This was the STEEL trial. This was a pretty simple design. It was done by the Germans. And it was a simple one-to-one randomization. They took patients with low-grade lymphomas, and they also had a couple mantle cell lymphomas in here. And they randomized them to either R-CHOP or bendamustine and rituximab. This was done as a non-inferiority trial because I think none of us believed that a single alkylator could beat CHOP. But surprisingly, the progression-free survival was dramatically better in patients that received bendamustine and rituximab. Overall survival about the same, 80% versus 78%. We repeated this study in the United States. It was called the BRIGHT trial. Actually, United States, Australia, and Canada. It was called the BRIGHT trial. And actually, it looked about the same. The progression-free survival was not as dramatic, the difference between the two, but bendamustine was still better, and overall survival was quite similar. Now, with bendamustine, there are some different side effects. I think we see a bit more nausea with bendamustine, a little bit more rash, but other than that, I think they're both quite well tolerated in patients that are fairly young and can tolerate chemotherapy. Now, I mentioned maintenance therapy is I think most of you know the background of maintenance rituximab. This was initially introduced following the results of the PRIMA trial. This was now, the initial data came back probably about 12 years ago. A very simple design here. It was a study done by the French where they looked at everybody that received some chemotherapy backbone, could have been CVP or CHOP. And then if they responded, they then were randomized to get observation, no treatment, or rituximab maintenance. And rituximab was given every 2 months for a total of 2 years. Now, the initial data showed a significant improvement in progression-free survival, but no difference in overall survival. About 5 years ago, we saw an update. This is now the 10-year data from that initial maintenance study. And again, we had a very nice benefit in progression-free survival. You can see it a decade later. If you receive maintenance rituximab, your odds of being in remission at 10 years, again, everybody has low-grade lymphoma, was 51% versus only 35% if you had observation only. Now, they also showed the survival curves, and I think it's really surprising. They were identical. So if you had maintenance rituximab, or if you had observation, absolutely, literally down to the point, absolutely identical overall survival. They also showed that patients that had progressed early following their first therapy were more likely to do worse than if they didn't. So what do we take out of this? I think what I think about this, if you like rituximab maintenance, it's evidence you should give rituximab maintenance. Patients have a longer progression-free survival. And if you weren't using rituximab maintenance, this shows that you don't have to use rituximab maintenance. So again, the survival curves are identical. So I don't think that, what that means, because patients eventually got rituximab when they relapsed, or because there's such good salvage therapies. But I don't think that it's critical that patients receive rituximab maintenance. Again, we have a decade-long follow-up, and there does not appear to be any difference in long-term survival, which I think is the holy grail here with follicular. So in my own practice, I do use maintenance therapy, but I only do it in select patients. So patients that get some induction regimen, say bendamustine, rituximab, or CHOP. If they're only in a partial remission after induction, then I'll give maintenance. There is some good data that you can convert patients from a partial remission to a complete remission with maintenance rituximab. And there is also, I also think that in patients that have high risk disease, this is a little more controversial, but patients who come in who have really very bulky disease, maybe kind of disease that's extranodal, there I will also consider maintenance, understanding that that is a group that is more likely to have a poor progression-free survival with kind of a standard therapy. Now, one of the things that I worked on for probably a decade was lenalidomide, and this drug, we've seen that it has multiple effects on the tumor microenvironment. Specifically, it can alter the function of T cells. It increases T cell recognition of tumor. It can also increase dendritic cell activity in the microenvironment. And we had some early work at MD Anderson in mantle cell lymphoma and myeloma that the drug could potentially augment ADCC. So we did an early phase 2 trial. This was in 2009, where we combined rituximab with lenalidomide. And the idea there was that we would augment the activity of rituximab, again, by changing the microenvironment. And that data showed a really nice complete remission rates, over 90%, with prolonged progression-free survival. So based on that study, we then designed a randomized trial. This was called the Relevance trial. And relevance meant Revlimid versus any chemotherapy is how we came up with the name. Pretty simple design. We randomized half the patients to get lenalidomide and rituximab, or R squared, and half the patients got R chemo. And the R chemo arm here was dealer's choice. So the doctor could choose any chemotherapy they wanted that was standard of care. So it could be bendamustine, rituximab, could be CBP, or could be R-CHOP. Then on both arms, because this was designed right after PRIMA study was announced, had some form of maintenance. And interestingly, here we saw no difference in, this is progression-free survival. At 5 years, they were nearly identical. You can see here that the duration of response was actually a little bit longer in the R squared arm compared to R chemo. Overall response rate was pretty similar, maybe a little bit better in the R chemo arm. So overall, I'd say the efficacy was remarkably the same with lenalidomide rituximab versus R chemo. Now, again, whenever you kind of see a randomized trial that has very identical efficacy, the next thing is you look at the side effect profile. And here we saw higher rates of neutropenia with R chemo. You can see that it was quite significantly higher here in the R chemo arm. This is despite the fact that this group had 3 times more growth factor use compared to R squared. We did see higher rash in the lenalidomide arm, which is probably not surprising. We all kind of know the background of these lenalidomide reactions in myeloma. But otherwise, they both looked fairly similar. One of the things I think patients often clearly like is there's no hair loss with R squared. And although we don't have longer follow-up yet, obviously, compared to CHOP, there's no significant effect on the heart with lenalidomide. So big picture here, for the first time, we were able to show a non-chemo regimen had identical efficacy as a chemo-based regimen without the common side effects. And now this study was designed as a superiority trial, so it did not meet its primary endpoint. However, Bruce Chesson, when he introduced this at ASH, he said it was the most positive negative trial at ASH, again, because we saw for the first time the ability of a non-chemo regimen to at least deliver similar efficacy as something like R-CHOP. So now one of the questions I often, I'll back up. In the Relevance trial, we did 6 months of R squared, and if patients were responding, we give another 12 months of R squared at lower dose, 10 milligrams of lenalidomide. However, in my own practice and in the early phase 2 trials, we only gave 6 cycles. And the only patients who went on beyond 6 cycles were patients who were not achieving did not achieve a complete remission. So one of the most common questions I get, and when I give this lecture, is how long should I give lenalidomide if I'm using this in the front line? And in my own practice, 6 months. You can see here that this is the progression-free survival, 6 months versus 12 months. It was a little bit longer here in the 12 months, but still very nice progression-free survival. We now have 10-year follow-up, and it's rated about 63% 10-year follow-up with 6 cycles. One of the problems with going beyond 6 cycles is in patients, especially who have complete remission, is we do start to see some neutropenia and thrombocytopenia that occur beyond 6 cycles. So I will continue on that. What about obinutuzumab? Now, there was I love simple designs because it's easy for everyone to understand it. So this was another simple design trial in the front line where they randomized patients with bendamustine to get one of 2 different CD20s, either rituximab. I'm sorry, I'm going to back up a little bit. This is actually a relapse study. This is from the Catalan trial. This was bendamustine, where they were randomized to bendamustine alone versus bendamustine plus obinutuzumab. And in this study, you can see there was a significant improvement in progression-free survival here in patients that received bendamustine obinutuzumab versus bendamustine alone. And this led to the first approval of obinutuzumab in the relapse setting. Now, this trial was a little bit different because they only included patients who had had prior rituximab. That's correct. Yeah, prior rituximab. So it's hard to know what this means because there was no rituximab arm, or rituximab therapy in this observation arm or in the bendamustine alone arm. One of the other issues, I think, with obinutuzumab, it's 1,000 milligrams, again, which is a bit higher than we get with rituximab. So the argument here is that, well, was it a dose effect? Or if this had been the BR versus bendamustine obinutuzumab arm when they had been similar. The other thing that you notice here is that when this curves start to separate at 6 months, which is when maintenance was started. So when they were both getting bendamustine, regardless of the CD20, there was no difference, and it only separated once you got this maintenance therapy started. Now, there was a similar trial, and I apologize that slide is not in here, but that was also randomized patients to bendamustine to obinutuzumab or rituximab. And that also showed that there was a benefit in progression-free survival with obinutuzumab. Also, no difference in overall survival. Now we've got all these front lines that are currently approved or common in practice. CVP, CHOP, bendamustine, and now R squared. So how do we decide? Let's assume a patient has been on watch and wait, but now has symptomatic disease or bulky disease or cytopenias. The first step, I think, is to make sure the patient's not transforming. Now that it could include either getting a PET scan or if the patient has not had a biopsy, repeating a biopsy. So what I'm getting at is if the disease begins to change, assume a patient is on watch and wait for several years, and all of a sudden they develop a very large node in a specific area. I usually will rebiopsy that node if I'd say for more than 18 months since their initial biopsy. I actually have a silly joke I use with my fellows. The best way to define a fast-growing lymphoma is if it's fast-growing. So in other words, if the disease changes clinical course, I always obtain a biopsy or get a PET. Now, if the PET scan has an SUV over 15, or if the biopsy shows transformation, then I think the treatment is obvious. It should be R-CHOP or something with an anthracycline. If the patient does not have evidence of transformation, either clinically or by biopsy, then I think usually bendamustine or rituximab or RCVP are probably the 2 best options. In patients that are a little bit older, I think that CVP is also fine. Again, this I put history of heart disease. Again, if CBP would also be a great option. I think that most studies have shown that CBP is probably associated with a shorter progression-free survival compared to bendamustine rituximab. So again, in my own practice, I don't use a lot of CBP anymore now that bendamustine is broadly available. Now, unfortunately, beyond that, there are no great studies. I don't think there are any really good scoring systems that can tell me who should get R squared or who should get R chemo. We are working hard at developing those scoring systems. These are now going to be based upon the microenvironment. We're doing several studies looking at gene expression profiles, and hopefully we'll be able to come to you in a year or two to tell you, this patient should get lenalidomide and this patient should get R chemo. But until then, I think both of them are perfectly reasonable options, and the decision should really be made around kind of what you're used to and the patient's understanding of potential side effects. Oh, and the last thing I put, all options are okay with CD20s. I think obinutuzumab or rituximab are both good options to include as a backbone with R squared or with bendamustine, CBP, or R-CHOP. I think, again, obin probably is a little bit longer progression-free survival, but as of yet, no clear evidence that it's going to change the long-term outcome of these people. Now, I mentioned, we've been trying for a long time to determine how to identify high-risk groups in low-grade lymphoma, knowing that there's such heterogeneous outcomes across patients, even with the same therapy. Now, this study came out now around 7 years ago. This was the PFS 24 study done by Carla Casulo. And what they looked at here, we took patients, this is from a kind of a national registry of patients treated mainly in the community. And what they looked at is they identified around 600 patients who had received R-CHOP as frontline therapy. And of those 600 patients, they found around 122 of them had progressed within 2 years of getting the treatment. And you can see patients who had progression or PFS within 2 years had a 5-year overall survival that was only around 50%. Now, this was dramatically different than patients who had actually, it's actually even better than 71%. 2-year overall survival. This is progression-free survival. Progression-free survival is actually even higher. It's in almost 90x%. So, but what this showed is that if you had no evidence of progression within 2 years, your long-term survival, look at the 10-year survival here, was sorry, this should be 10-year. I think that's the difference. 10-year overall survival here was like 71% versus 50%. So this tells me several things. The first is that, not surprising, that if you respond to therapy and you stay in remission, you're more likely to do better long-term, regardless of what we gave you in the salvage setting. But the other thing this really points out that there's a group of patients, and this is about 70% of patients, who are not going to die of their lymphoma. We've looked now, for example, there have been studies done in Spain and Italy where they compared patients who did not progress within 2 years to patients without lymphoma from their national databases, from patients with like diabetes. And the survival was identical. So what, again, that's saying is that if you don't progress within 2 years, statistically, your odds of dying of lymphoma are no higher than someone without lymphoma. So again, the survival, long-term outcomes are identical to patients that don't have cancer. And so what that again tells me is there's a population of people here that we have to be very careful about giving intensive salvage regimens, because statistically, they're not going to die, at least of lymphoma. So these are not a group, again, that we want to send to auto transplant or allo transplant that has a mortality, of 5 to 15%. Now, since this came out, there has been a little bit of controversy about who are the patients here in this high risk group. The Canadians did a study where they looked at their patients who had progression of disease within 24 months. Now, these patients all had either bendamustine or CBP, but you can see that in the patients that had progression of disease within 2 years, this is the POD24 here, 76% of them were transformed disease or in the process of transforming on repeat biopsy. So this would suggest that, again, in this high-risk group, it's mainly transformed disease that are driving these really bad outcomes. Again, which goes back to my prior point, when you start therapy, you have to make sure that they're not either transforming or in the process of transforming. Now, we looked at this same type of data at MD Anderson. This was published a couple of years ago by my former fellow, Chan Chea. And here, again, we did the same thing. That we looked at all of our patients in the database. We actually had R-squared, R-CHOP, and bendamustine. And we separated them, again, into patients who had progressed within 2 years versus not. And these two top curves, this very top curve in blue is progression of disease without transformation. If you do not progress within 2 years, and this is if you progress within 2 years. So here you can see the curves are not as dramatic as the prior paper. They did do worse, again, if they progress within 2 years, but still a 10-year survival was still over 70%. These curves are patients that are transforming. So if you transformed beyond 2 years or under 2 years, these are your outcomes. These patients do terribly, unfortunately. So if you progress within 2 years of initial therapy, your median survival is less than 2 years. So these are the folks, again, that we should be thinking about stem cell transplant, CAR T cell, some alternative regimen, clinical trials, because at least statistically, these folks really don't do well with salvage therapy. So I'll give you a couple slides about PI3 kinase inhibitors. Unfortunately, these are, I think, an effective class of drugs which are probably starting to go away. There were 4 of these drugs that were approved in the United States. The reason we use these drugs is we know that the PI3 kinase pathway is very active in low-grade lymphomas. There was a lot of early phase 2 trials that showed that overall response rates using a PI3 kinase inhibitor were all around 50 to 60%. Most of these trials were all done in very relapsed patients. These were usually done in patients that had progressed after an alkylator, were refractory to rituximab, and were usually in their second or third line of therapy. So despite that pretty tough population, again, almost every study showed that your remission or your odds of response were around 50%. And most of them, you got around a 1 year duration of response or about 10 or 11 months progression-free survival. And that actually these are all single-arm phase 2 trials, led to approval in the United States for all of these drugs. 3 of them are oral, idelalisib, duvelisib, and umbralisib, and copanlisib was an IV formulation made by Bayer. Now, the problem with these drugs is that they were associated with some pretty tough infections, or I should say side effects. Initially, we saw diarrhea and colitis in the idelalisib trials. This actually led to several phase 3 trials and CLL and follicular lymphoma being stopped. And subsequent phase 3 trials also saw increased infections, including increased mortality in the PI3 kinase inhibitor arms. And we saw this in almost all of these trials. And just more recently, we saw some randomized trials with umbralisib that had increased mortality. This was actually driven by patients with COVID. And because of these group of side effects, again, colitis, infections, all of these drugs are now pulled off of the market in the United States. I think copanelizumab was the last one, but I believe this is actually now off of the market. I'm not sure if these are still available ex-US or in India. Unfortunately, they are effective drugs, especially in tough to treat populations, but at least until we can redesign these trials, potentially change the dose, change the schedule, they're off the market. There is still, I believe, 2 of them that are in clinical trials from different companies that are using different dosing schedules, and you'll probably see some updates at ASH around those drugs. Potentially still have a future in the market if we can figure out the side effect profile, again, because they're very, very active. So again, what about in the relapse setting with lenalidomide? You could tell I'm very excited about it in the frontline setting. The Augment trial looked at the same regimen, lenalidomide rituximab, very similar dosing, and compared it to rituximab plus placebo. These patients, it was around 350 patients in the trial. All of these patients had prior rituximab, and all had low-grade disease. They included marginal and follicular. And in this study, unlike the relevance trial, there actually was a really nice benefit in progression-free survival. You can see with the R-squared arm, significantly longer progression-free survival than rituximab plus placebo. Bruce Chesson also reported the survival data. It looks like there actually may be a marginal improvement in long-term survival with R-squared compared to rituximab alone, again, in the relapse setting. Overall response rate, not surprisingly, with this progression-free survival curve, was significantly longer with R-squared compared to rituximab only, and almost double the CR rate. So I think it's a great option for your second and third line follicular lymphomas. So other drugs I talked to you about, how heterogeneous follicular lymphoma is with regards to genetic makeup. Just about a year or 2 ago now, we saw the first drug approved based upon a mutation in follicular lymphoma, and that's tazemetostat. It hits EZH2. This is a mutation that is seen in probably around 20% of patients with relapsed follicular lymphoma. The study actually was designed to look at, the initial registration study was designed to look at patients regardless of their EZH2 status. So actually they enrolled patients either with a mutation or without a mutation. So you can see it was around 100 patients, around half were wild type, half were mutated. Response rate was higher in patients who had a EZH2 mutation, but even in wild type, you had around 34% response rate. CR rate not so good. If you look at progression-free survival, it was better in the mutated EZH2, but again, surprisingly, even wild type EZH2 didn't do terribly. And if you look at around 2 years, the curves begin to come together with around 20-25% of patients who can achieve a remission at 2 years out with a EZH2 inhibitor. So with these curves, even though the drug works better in mutated, it was approved for patients regardless of mutation status. And so in my own practice, I think this is a great drug to use. The good news is that the side effect profile is extremely mild. We've seen some rare cases of some side effects in the pancreas, but that's really quite uncommon. You can see if you look at cytopenias specifically, nothing really. I mean, there's, I think 5% of patients can get some grade 3 thrombocytopenia, but almost no lymphopenia. Infection rate is very, very low. So I think it's a very nice, it's a very safe drug. One of the problems I think is that in the United States, and I'm guessing probably in India, we don't normally check EZH2 mutation status. It's not common, part of the common panel. So when I see patients in their second line, I don't know their EZH2 mutation status. So I actually have been using this drug regardless of mutational status in patients. And I will send it. I think that as the panels begin to change, I probably would use this a little bit more often, but I'll show you my algorithm for relapse setting in a second. And so what about CAR Ts? So low-grade lymphomas we've been a little bit slow to or slower to develop CAR T cells. As we all know, these are kind of one of the most exciting things for acute leukemias and large cell lymphoma. We now see some data in mantle and myeloma, but there were kind of two pivotal trials now, which have led to the approval in low-grade lymphomas. The first of these was the ZUMA-5. Sorry, let me back up. All of the two CAR T cells that are approved in Follicular are both targeting CD19. It's really the same product that was approved for large cell lymphoma. Axicaptogene, again, I think you probably know is approved in large cell lymphoma. It recently got approval about a year and a half ago for relapsed follicular based on this trial. This was a phase 2 trial. They enrolled around 100 patients. And in this study, you can see that a pretty good progression-free survival here. This is the blue here is follicular lymphoma, 95% overall response rate, phenomenal overall response rate with a complete remission rate of 81%. So extremely active. Again, these patients are all in their third line of treatment or beyond. And again, extremely active with progression-free survival, not yet reached at plus 2 years. Now, the downside of CAR T cells, and I think especially in a low-grade population, is there are unknown side effects. Unknown meaning unpredictable. They occur in the minority of patients, but can be quite significant. If you look at grade 3 cytokine release, it was seen in only about 7% of patients. But neurologic adverse events were grade 3 in around 15% of people. And although this may not sound a lot, if you use these drugs very often, you know that the grade 3 neurologic events can be very scary. These can be anything from seizures to patients can become unresponsive. Occasionally, we've seen things like cerebral edema. So, I think that I still am very careful about the population of people with follicular that I give CAR T cell, not because of the efficacy, but because of these side effects. Unfortunately, they can occur in a rare but unfortunate group of people. A lot of these, thank goodness, are temporary, but occasionally can be permanent. So just this year, I published a paper with another CAR T cell. This was T-Laclusil. This came out in Nature Medicine at the beginning of the year. And here, this is also an anti-CD19 CAR T cell. It has a little bit slightly different co-stimulatory domain. And similar to the prior trial, we also saw very nice response rate, overall response rate, almost 90%, 86%. And progression-free survival now was, again, this is still, a lot of these patients, you can see why these sensor curves are still in follow-up, but progression-free survival well over 2 years. So it looks very, very active. One of the good things about this drug, I think, is that the side effect profile appears to be less than what we've seen with axicaptogene. I'm a little biased, but you can see the cytokine release, 0% grade 3. Neurologic adverse events, only one event was a grade 3 or higher. Now, like any CAR T cells, again, there are these occasional prolonged cytopenias. We do see B cell depletion. Sometimes this can occur for 6 to 12 months after therapy. This was actually seen in all CAR T cell products due to the target. Obviously, the drug is hitting all CD19 positive cells, including normal B cells. So patients will have lymphopenia. Sometimes that can be prolonged, and that's also associated with hypogammaglobulinemia due to their low B cell counts. So what to do? What I've tried to show you, there are a lot of options in the front line, also a lot of options in the relapse setting. Now, when I'm thinking about which one of these to pick, clearly, I know we're all oncologists. First thing to do is look at what they've had previously. Obviously you want to avoid regimens where there's clear resistance. I think the duration of the prior therapy is probably the most critical thing when I'm thinking about what to use next. Number of prior lines, rituximab sensitivity, EZH2 status. I should probably put asterisks here because usually we don't know it, but until we start testing for it, I think EZH2 inhibitors are great. And obviously, the goals of therapy, the age of the patient, and cost should be an important factor. I hope you guys can see this. It's a little bit small print. I'll share the slides, but this is kind of how I go through thinking about sequencing a patient in 2022. So first thing, obviously, decide if the patient needs treatment. If they do, again, based on bulk, symptoms, cytopenias, then the next thing is, can they tolerate chemotherapy? Now, again, with the average age of this disease being 61, as you know, there's a lot of people here who are going to be quite older, 85, 90 years old, if they have comorbid conditions. I still do a lot of single agent rituximab. This is associated with a response rate of around 65% and still works very, very well, progression-free survival around 24 months. If I suspect transformation, I do R-CHOP. If they are not transforming, then I will do bendamustine rituximab or R-squared. And this is just a discussion with the patient. And I put maintenance is dealer's choice. This is kind of up to you. This is again, I don't have a strong opinion one way or the other. I tend to usually not do it, again, unless patients are only in a partial remission. Now, what if, I'm trying to advance, there we go. What happens when they relapse? So this is at relapse. Again, the first thing is rule out transformation, either with a PET scan, think about it. Is the disease progressing quickly? If there is any change in the behavior, I absolutely repeat a biopsy. If they're transforming and they haven't had R-CHOP before, R-CHOP. If they're not transforming, then it's basically the same. You have the same options. Now, I did this cross arrow. So if they've got bendamustine rituximab, they're not transforming, then I switch to R-squared. If they are have gotten R-squared and they're not transforming, then I get BR. So just switch the regimens. If there are, this is a really nice one. I think that if they had a long remission with Rituxan alone in an elderly patient, I'll just repeat rituximab alone. I've had several patients where I've done rituximab as a single agent every 3 years, every 4 years, and I can sometimes get a decade of remission just out of going Rituxan without any other backbone. Now, if now we're at the third line, what happens now they progress after R-squared or BR? What's next? Here, I'm assuming that they've gotten both BR and R-squared. If they're young and the remission was short, and what I mean by short, if they progress within 18 months of these regimens, so 18 months and then 18 months again, then I think, you need to think about CAR T-cell. There are some newer regimens like BiTE, stem cell transplant. If they're older and they're not fit, then you've got a lot of options. I think EZH2 is a great drug. As I mentioned, it's fairly well tolerated. I actually think about this regardless of the mutation status. If they, I put PI3 kinase inhibitors, although this is now probably not available in most places, but you can switch the CD20. If they've had Rituxan, I'll switch to obinutuzumab. Sometimes I've done some single agent Cytoxan. You can do rituximab alone, or even radiotherapy to symptomatic disease if they've gone now through all of these different regimens. So again, when you get to the third line, if they're old, I think tazemetostat is probably my treatment of choice. Clinical trial, or again, repeat a anti-CD20. So I'm going to talk, Dr. Agarwal, how am I doing on time?
No problem, sir.
Okay, great. So let's do a case. And I welcome anybody to chime in. If no one says anything, then I will just keep talking. So this is the first case. A 66-year-old patient has bulky disease. Let's say it's advanced stage, so above and below the diaphragm. Biopsy showed grade 2 follicular. Patient got bendamustine and rituximab, got a great remission, but now 18 months later, so it's within 2 years, has progression above and below the diaphragm. PET scan shows, again, multiple sites of disease. It's bulky. SUV is around 8 to 12. So I intentionally made this kind of borderline between fast and slow. This is the PET scan. You can see that kind of bulky disease. It looks like the patient actually has developed hydronephrosis here on the left. You notice there's no uptake in that left kidney, and looks like there's a mass here on the left. Again, I'm going to assume here that this is probably blocking the left ureter, has some disease in the armpit, and then as well as in the groin. So we biopsy this because it looks kind of yucky. But good news is the biopsy still shows grade 2 follicular. What do we do? Again, patient got BR. Options are R-CHOP. We could do switch to obinutuzumab plus bendamustine. We could do R-squared. Rituximab is a single agent, CAR T-cell transplant, or PI3 kinase inhibitor. Any ideas? If not, I will tell you. So here I think this is a bit of a tough case, but unfortunately one that's not that uncommon. The first thing here, again, is to rule out transformation, because the patient, it's within 18 months. And as I mentioned, around 70% of these patients who are progressing within 18 months are going to be transformed, also has bulky disease, and has threatened organ function. So this is one of those cases where it's kind of a yucky looking follicular, despite the fact it's not transforming. So here, I think the two options would be lenalidomide rituximab or R-CHOP. Depending on what the kidney function looked like, I might actually pick R-CHOP here. And that's because, again, if the patient has hydronephrosis on the left, we need a rapid response. And R-CHOP tends to work a bit faster than lenalidomide and rituximab. Also, with lenalidomide rituximab, occasionally we'll see a flare. This happens in around 10% of patients, where the disease will actually get bigger on day 14 before it gets smaller. I probably would avoid rituximab single agent here because the patient's progressing within 18 months. I also would probably not repeat bendamustine because at least the patient's got lots of other options. It's a little too early to go to CAR T-cell or transplant, I think. But neither of these are approved in the second line setting. And again, PI3 kinase inhibitors, although they're going off the market, even when they were approved, I think that with the response rate of around 50%, I wouldn't pick that first. So lenalidomide or rituximab or R-CHOP. And if I had to pick one, I probably would go with R-CHOP just because of the disease. It goes back to that not good joke I told you before. The best way to tell if it's fast growing, if it's fast growing, and this disease does not look too good. So let's keep going. What about another case? Let's say this person has now in the third line. So he had BR, great remission. Unlike the prior patient, has a fairly longish remission, goes 3 years, but eventually progresses. Biopsy does not show transformation, and then we give him R-squared. Works great, has a complete remission, lasts 2 years, and then gets a PI3 kinase inhibitor with only a partial remission. So now it's 3 lines of therapy. You can just do the math. The patient is now, about 6 years or so from their initial diagnosis, but now has disease that are progressing above and below the diaphragm. Repeat biopsy shows no evidence of transformation. What next? So I picked this case because the patient is in the fourth line, has kind of exhausted, the kind of standard regimens, BR, R squared, and it is now again progressing, but still not transformed. So here I think there are several options. If the patient is still fairly healthy, I think this is a great case for a CAR T. Even though it's been 6 years, they've gone through most of the effective regimens outside. The only thing they really haven't gotten is tazemetostat. And tazemetostat is associated with a 1-year progression-free survival. So this person, assuming they have the standard remission, we're going to be dealing again with picking a treatment option in about a year. So I think that a CAR T cell is definitely probably the most effective choice in this patient. If it's not available, either because the patient is not in an area where they can get it, they don't have insurance, you could do CD20 again. This patient, if you see that when they had BR, they went 3 years. When they got R squared, they went 2 years. So technically, the patient is still Rituxan sensitive. So this would be, again, you could do rituximab single agent, obinutuzumab single agent. Again, I think if the patient is well funded, as I mentioned, CAR T cell is a great option, or tazemetostat if they're not a CAR T cell candidate. So my last couple slides, I just want to talk about transformation. I've talked a lot about making sure you rule this out whenever the patient progresses. I think we've probably all seen these curves before. The risk is fairly linear over time. It's around 2% a year. Interestingly, these are old data here. We used to say that the lifetime risk is somewhere around 30, 35%. There was recent data out of Italy that suggests it's probably closer to around 15%. That may be because Rituxan and other things are changed in the natural history. But I think the takeaway here is that the risk of transformation is that each year is about the same. It goes up each year by about the same amount. And so you can never really rule it out by looking at how long the patient has had the disease. I really look at the risk of transformation based upon the clinical presentation. We know that, as I mentioned, there doesn't appear to be any effect on transformation risk, regardless of what the patient has had. This is studies this was done, I believe, out of the Mayo Clinic, this was Iowa, and they looked at prior exposure to alkylators, to things like R-CHOP, and interestingly, the p-value, it's about the same. So again, R-CHOP does not prevent subsequent risk. And the last thing I'll tell you is that when deciding what to do at transformation, the most important thing to look at is prior exposure to R-CHOP. So if the patient has seen prior R-CHOP and they're transforming, go to CAR T cell or auto. If they have not had R-CHOP, use R-CHOP. And that's based on this data. You can see that the outcome here, if they've had prior R-CHOP, really not very good, versus if they've had R-CHOP. This is their survival curve. So they're pretty good. In other words, you can actually get pretty good long-term outcomes if they have not had R-CHOP. And that's it. I think that hopefully I've been able to show you, the good news is that the disease is getting, and the disease is not getting better. We're getting better at treating it. That there is a big group of patients who, thank God, will probably never die of their follicular. And so we have to be very careful about what we give these low-risk patients, because there's a real chance of harming them. Lots of good drugs for patients that have relapsed disease. I think that probably, to me, the highest unmet need is trying to identify who is at high risk. But until we have these biologic models, I think risk is really subjective. This is somewhat, as a doctor, you kind of get a feel for this in your own clinic, I'm sure. If patients are beginning to behave differently, the disease is changing, they have bulky disease, extranodal disease, always think of potential transformation. CAR T cells, and there will be new versions of CAR T cells and BiTEs. We expect to see the first bispecific T cell engager approved this year. Well, I should say 2022 for Follicular. And the early data looks phenomenal. Actually, the complete remission rate is just outstanding with these drugs. So stay tuned. We'll have more drugs for you soon in the third line and beyond. And I will stop. And I'd love to take questions or discussion.
Thank you so much, sir, for updating us on this subject. Beautiful, lovely update. Enjoyed listening to you and those two cases. We have our colleagues here who would like to interact with you, and we will use the raise hand sign. So those of you who are interested in asking questions, please raise hand. And you can open your videos, that will be more interactive. So we start with Dr. Panda. Unmute yourself.
Good evening, sir. Am I audible?
You are.
I can hear you great.
Yes. Thank you, sir, for this opportunity. Excellent presentation, which was very much focused and clinical oriented, helping us guiding in our therapy. Sir, my question is, sir, in transformed follicular lymphomas, whether there is any predictors of transformation that we can predict at the baseline when we are starting chemotherapy. So whether there are some predictors, and at present, as far as treatment is concerned, we are guiding treatment based on patient symptoms only. So whether it is now time to decide treatment based on tumor microenvironment, mutational landscape, and taking into account the disease biology and all those factors. What is your take, sir?
Yeah, so this is unfortunate. This is a sad answer to your question, because the answer is no. We do not have good, so that we have been looking at trying to develop biologic predictors. There's a very nice paper by Sarah Hewlett, H-U-E-T Hewlett, where they developed a 23 gene score to look at outcome following. This was taken from the PRIMA trial. They looked at 23 genes that were commonly mutated, and they found that if you had some of these genes, you're more likely to progress after R-CHOP. But then they took that same score and they applied it to bendamustine, and guess what? It didn't work. And then, so it only worked with R-CHOP. We've looked at transformation risk. You'd be shocked, but there has been no good studies looking at the genomic profile of patients that transform. Unbelievable. It's still, actually, this is a great, this would be a great paper for someone in India. If you collected 150 transformed cases and just published the genomics, no one has done this in any good way. So we don't, and that possibly because it's so heterogeneous, that what drives transformation is probably different in different patients. But the short answer to your question is we do not have any good biologic predictors of transformation at diagnosis. We've looked at things like LDH. People have looked at peripheral lymphocyte count. We've looked at SUV, bulk of disease, FLIPI, and they're okay. I mean, patients with a higher FLIPI, patients with high LDH and more bulk are more likely to transform. But there are many patients who can have those factors and not transform. So it's really, I don't use any of those in my clinic to say a patient should get R-CHOP. And what I was showing you earlier, it doesn't show that giving R-CHOP early prevents transformation. They still transform. So I would not pick therapy based upon any clinical factor, because it at least today, it doesn't appear to change the outcome. I'm hopeful. So Dr. Agarwal may know, I also run a lab in Boston now, and we're doing a lot of this genomic sequencing. And one of our big projects is working with the Follicular Lymphoma Foundation to sequence large groups of patients to try to develop these models. But I apologize to tell you today it's not ready. So today I think you just have to use your clinical judgment. Sorry, that's not a great answer. I hope it's one of my great frustrations that we don't have this. In 2022, we still don't have a genomic predictor of transformation. It's terrible. but
Thank
I'm
you.
working
Thank you
on
so
it.
much, sir. Thank you so much, sir. Sir,
Yeah.
one more question, sir. Sir, should you think there is role of BTK inhibitors like ibrutinib or something like that in the treatment paradigm of follicular lymphoma?
Yeah, so ibrutinib, this is another one of those, you're asking me all the hard questions. Ibrutinib is, so one of the one of the things that made me famous, I did all the early trials for ibrutinib and the phase 1 trials. And as you know, I'm a follicular person. Well, I did follicular and phase 1. And so it's joking, it was just fate that the one disease where ibrutinib does not work very well is the disease that I focus in. So I did these early phase 1 trials for ibrutinib, but then I did probably 3 phase 2 trials with ibrutinib in follicular, and the response rate is just not very good. In rituximab refractory, the response rate was 4%. Across the board, it's around 20%. But I generally don't use ibrutinib in follicular unless there's no other options. So we don't know why, because the B cell receptor pathway is definitely active in follicular. I think there are probably so many alternate pathways, and we had hoped, I'm giving you a lot of background, we had hoped that PI3 kinase would be the ibrutinib of follicular. And so we, as a group, we when the early trials with ibrutinib were not good, we started moving towards towards PI3 kinase inhibitors. That was going to be the oral drug, the ibrutinib of follicular. But unfortunately, the side effect profile led up those drugs. Most of them are now off the market. So again, that's a long answer to your short question. Ibrutinib is unfortunately not a very good drug for follicular. Yeah.
Thank you so much, sir. Thank you.
I wish it was, because, but yeah. There are some last thing, there are some combination studies. There was some early data showing that ibrutinib possibly could augment CD20s. So there are some phase 2 trials that have not yet been presented with ibrutinib. Sorry, it's zanubrutinib plus obinutuzumab. So we'll see what those show. But as a single agent, no. Maybe as a combination.
Okay.
Thank you,
Thank
Dr.
you, sir.
Thank you. Dr. Rajini Priya, your question.
So, thank you, Agarwal sir, for the opportunity. Thank you, Dr. Nathan, for the wonderful talk and the case-based discussions. So my question again is a case. So I have a 48-year-old male patient who presented with bilateral neck swelling of almost 8 to 9 months of duration. And now he presented with dysphagia for solids. So he was evaluated initially with a lymph node biopsy suggestive of a low-grade lymphoma. And we had gone for IHC, which is suggestive of a grade 2 follicular lymphoma. So after the IHC, we had proceeded for the PET CT scan, which showed lesions in the oral cavity, oropharynx, hypopharynx, and infra and supradiaphragmatic nodes. Bone marrow aspiration is also suggestive of involvement of the marrow, the SUV is between like 8 to 10, sir. Bone marrow aspiration was done and biopsy was done, suggestive of involvement of the bone marrow with the low-grade lymphoma. So the patient is symptomatic with dysphagia and high disease burden. We had proceeded with treating the patient with 6 cycles of bendamustine rituximab combination. Right. So end of therapy PET had shown complete metabolic response of all the lesions, except a small right level 2 cervical node, which is like only 1 to 1 centimeter. Yep. So we had gone for biopsy of the node, the only site of disease, and it came out to be a DLBCL. Oh. So it's so my question is like, how frequently do you see at the end of therapy transformations? Because like clinically it's a long history, and the biopsy all is suggestive of follicular lymphoma. So how commonly you see patients presenting with the transformation at the end of therapy? And how do you go about treating the patient? Because it's only very small node left. Can we go with RT, or it's being a transformed lymphoma, do we need to go with treating with R-CHOP? The other question is there any role of transplant in this patient, as a patient is an young patient?
Yeah, so this is a great...
And a transformed lymphoma.
Yeah, it's a great question. So how old is the patient again?
48-year-old male, sir. Young patient.
48, yeah. So this is interesting. the patient probably had transformation at the beginning. And what happened, as you know, is the bendamustine probably eradicate all the low grade, and what is left is this small kind of spot of large cell. So this is what we would call a composite lymphoma. The standard of care is to do R-CHOP. It stinks because this guy is, he just finished 6 rounds of chemo. He's probably cytopenic, I'm guessing, but he has large cell lymphoma. I would not do stem cell transplant again because he has not had R-CHOP. So again, in a standard of care, this guy is at risk because if he has large cell lymphoma after 6 cycles, that means he's alkylator refractory, and he's potentially had Rituxan. So unfortunately, he's kind of in a little bit of a scary position. So I would do R-CHOP. I would not, if he was older, if he was 80 or had some other issues, then if he had cardiovascular disease, then I agree with you. I would do radiation. But in a 40-year-old, you can still cure this guy. So I would definitely do R-CHOP. To me, the question is how many cycles. What was his stage at diagnosis? You said he was
stage 4. Yes, bone marrow involvement, stage 4, sir.
Yeah. So if he can tolerate 6, I would try to get to 6. You could, I suppose you could get creative and do 3 plus RT, but I think what I'm getting is, this is where you saw transformation, but there could be some other occult transformation somewhere else. You just can't see it. So I think the safest thing is to give him R-CHOP. Yeah. I would not do transplant. No transplant, only if he progresses.
Only 6 cycles of R-CHOP. Okay.
I think it's the right thing. If he gets into trouble, if you get, again, he's already had BR. Let's see, if you get 3 cycles and restage. So if he gets into trouble, meaning if he starts to not recover his counts between cycles, you could pause early. So again, if you can't get him through 6 cycles, you could do 4 plus XRT. But there, I would really save that as only a backup.
Okay.
Yeah.
Okay, sir. Thank you, sir.
Great case.
Sir, I have other questions, sir. So,
Sure.
So is there any subset of patients where you prefer obinutuzumab over rituximab in the frontline setting?
No, I don't think so. There was a little bit of data in the I think it was called gallium. I think was the patients with high IPI maybe did better, but still the survival is about the same. So I don't.
Okay, sir. Thank you, sir.
Thank you, Dr. Rajani. Dr. Javed Rasul. Unmute, Javed. Unmute. No, we can't listen to you. Unmute yourself. Okay, we'll come back to you. Dr. Archit Joshi.
Good evening, sir. First of all, thank you so much, sir, for the really highly enlightening lecture. So I have 2-3 questions, maybe silly questions also, but just I want to reconfirm from yourself. So, sir, how do you treat follicular lymphoma grade 3A patients? So do you treat them as the follicular lymphoma patients, or do you treat them as diffuse large B-cell lymphoma patients?
This is a great question. So 3A, so 1 and 2 easy, then low grade. Grade 3B, large cell. 3A, here I need some more evidence. So here 3A, I look at the clinical picture. So if you're 3A and you have a high Ki-67 on path, or the PET scan is SUV more than 12, or if it's behaving aggressively, so the disease has grown quickly in the last 6 months, patient has maybe bone disease. I don't mean bone marrow, but bone, like primary bone. I treat it like large cell lymphoma. If the Ki67 is 8%, SUV is low, I treat them as a low grade. So 3A, I look at other factors, and the main things again are PET scan, Ki67, and clinical behavior. So there I can treat either way, depending on how the patient looks.
Thank you, sir. So next question is, nowadays some molecular subtypes of follicular lymphoma are available based on the molecular cytogenetics. Do you feel that these subtypes, according to the subtypes, will we be able to change the treatment lineup or in near future?
I hope. Today, no. Yeah, we hope so. We've done, as you probably know, there's a lot more work in large cell now, where there's now like 4 different systems to subtype large cell lymphoma from Boston and the NIH, and there's ABCGC. But we don't use them as a therapy to decide therapy. You may know there were several, a couple different papers where we tried to separate ABCGC large cell, for example, with ibrutinib or R-squared, and they failed. So meaning the outcomes would look similar. So in follicular, we're even worse. We have a couple subtyping systems, but I don't use them to decide therapy. No. And we have a big argument in the field about whether this will ever happen, mainly because it's so heterogeneous. And remember that second slide I showed you, unlike large cell, it's just like it looks like I don't know if you guys remember from the 1990s, you had those car equalizers with all those lines. If you look at the genetic landscape of follicular, it's so broad that we've had a hard time classifying them to discrete groups, which is why I think maybe microenvironment is really the way we target it. Microenvironment meaning microenvironment targeting drugs like CAR T. It doesn't matter what the mutational profile looks like. But yeah, no, the short answer is no, we don't have a good system to classify and use it as a treatment decision.
Sir, last question, sir. Any experience on subcutaneous formulation of rituximab in any of the?
Yeah, I think it's probably, I was suspicious in the beginning because I wasn't clear that, it would, for example, with R-squared, if it would have the same, with R-squared, we use lenalidomide, we're using this as a ADCC type augmenter. But it looks like the data, I've actually now, I'm pretty convinced, I've used this now quite a bit, as long as they don't have a significant side effect with the infusion. I've been moving to subcutaneous, even with lenalidomide. So it seems to work pretty well. And patients definitely like it better. Yeah.
Thank you, sir. Thank you so much.
My pleasure.
Thank you, Dr. Archit. Dr. Javed, are you ready?
Sir, thank you, sir, so much. Am I audible, sir, now?
You are.
Yes.
Thank you, sir. Sir, Dr. Nathan, Professor. Sir, I have one, as we go about the literature, when we say lenalidomide in combination to obinutuzumab, they say that it has around 6% risk of developing a basal cell carcinoma. So do you have any experience, sir, on that statement? And second question is, does dual inhibitors of EZH1 and EZH2, they offer any benefit over selective like EZH1 only or EZH2 alone? Does dual, like we have aluminostat, does it offer any advantage over selective?
Yeah, sure. So with the first question, in lymphoma, we have not seen increased secondary cancers with lenalidomide in the randomized trial. Now, when I say increased, that's increased over chemo. So we looked at in the relevance trial, this is Revlimid rituximab compared to our chemo. The secondary cancer rate was actually less than our chemo. That doesn't mean that we know that chemotherapy, immunosuppression with chemotherapy also causes increased risk of skin cancer, basal cell squamous cell carcinoma. So there probably is some increased risk compared to a population that's untreated, but it does not appear that it's higher than with chemo. so I don't know. Let me back up. We have also looked at with R squared. We now have around 12-year follow-up with our phase 2 trial with lenalidomide in lymphoma, and there does not appear to be an increased risk of. We do see some increased skin cancers for sure. I have not seen increased solid tumors like lung, colon, other things. So I would say that until we know more follow-up from the phase 3, I do watch my patients. If they get a skin lesion and they've had prior lenalidomide, I would refer them to a dermatologist, make sure it's nothing. But what I'm saying is that I wouldn't not use lenalidomide instead of chemotherapy because of a skin cancer risk, because I think you also have a skin cancer risk with any alkylator is also going to increase your skin cancer risk. Do you get me? I think, yes, there's a risk, but I think it's in everybody who has chemotherapy or lenalidomide. I don't know if it's in any higher. The only way we can know for sure is with a phase 3. And the phase 3 trial today with 3-year follow-up shows no increased risk over chemotherapy. Now, the other question, EZH1 versus EZH2. There is another EZH2, it's a combined EZH1/2 inhibitor. I think it's by Pfizer. The data looks about, clinically, the data looks about the same, the response rate. So at least clinically, I don't know if there's a benefit of a combined EZH1/2 versus an EZH2. But we'll see. There are no head-to-head comparisons that I know of.
Okay, sir. Sir, another question is, usually the combination cause more toxicity, sir. But we know that amrelosib plus rituximab, anti-CD22, rituximab, they mentioned that there was no safety concern in this combination, means that it was safe compared to the monotherapy. I myself wonder, sir, that compared to monotherapy, how could the combination be safe with this AZH2 inhibitor and anti-CD22, amrelosib and rituximab?
I'm sorry, I didn't. So this was ublituximab.
Sir, anti-CD20.
So that
plus amrelosib AZH2 inhibitor. So the combination, they said that it was safe compared to the monotherapy if we would use any of these drugs as a monotherapy. But I wonder whether how could it be safe once we use them in combination? We expect in combination is more toxicity usually, sir. So I couldn't understand that point.
So I think you're talking about PI3 kinase inhibitor, not an EZH2. Yeah, the umbralisib is a PI3, but that one is so that was umbralisib and ublituximab was this regimen. And what you're referring to, we looked at this was the Unity trial. This was a trial where we looked at ublituximab and umbralisib in follicular and marginal. And so what we found was that when you look at we looked at PI3 kinase inhibitor compared to PI3 kinase inhibitor plus CD20. So there was no increased side effects if you added CD20. There was definitely increased side effects compared to a CD20 alone. So what we're talking about is a PI3 kinase inhibitor plus a CD20 was no more toxic than a PI3 kinase inhibitor alone. So adding the 20 did not add a lot of additional side effects, not the other way around. So adding a PI3 kinase inhibitor to a CD20 definitely adds side effects to a CD20, but we're talking about at the backbone of a PI3 kinase inhibitor didn't appear to be any worse with a CD20. And there we were looking at mainly things like diarrhea and rash, because these are the things we were most worried about with PI3 kinase inhibitors. And I think that question now is not quite as important because the PI3 kinase inhibitors are unfortunately going away. So I don't know if anybody will use a doublet or a singlet or a single drug, but yeah. So I'm not sure if I answered your question. We did not see increased side effects. I was the PI of that trial. We didn't see any increased side effects of adding a CD20. But we were mainly looking at things like diarrhea and rash. Yes.
Okay, sir. Thank you.
All right. Thank you.
Thank you.
Thank you.
Dr. Aditya.
Thank you, sir, for the wonderful update. So I'm going to ask you two questions regarding the maintenance, and they might sound a bit naive to you. So,
No, not at all.
So when we talk about follicular lymphoma, so we are dealing with a malignancy that is quote unquote incurable. So regarding the maintenance, rather than following a limited duration maintenance, can we have a paradigm where we can give maintenance beyond 2 years, something that we do in myeloma nowadays, something like rituximab or lenalidomide? And what are your views?
Yeah, so we did Brad Call, this guy, he was where was he? He was in, I think, Minnesota. Was he Minnesota? I don't know. He's in Minnesota. Anyway, he's now at St. Louis, and he did a study called the RESORT trial, and RESORT stood for rituximab. I think it was standard dosing or retreatment, RESORT. And what they did here is exactly what you're asking. They give patients, this was all low grade, but they gave patients rituximab for 2 years, or they gave patients, actually, that's not true. They gave patients, I think it was less than 2 years. It was about a year. And then the other patients, they gave maintenance, continuous maintenance forever until they progressed. So no 2 years. They just kept on going. Could be 5 years, 10 years. And turns out survival was no better. And what we call the time to next treatment. So when did they need something other than Rituxan? It was the same in both arms. And I worry a little bit about the development of resistance, because remember, this disease, unlike myeloma, this disease, hopefully, we're going to be treating these patients for years, if not decades. And so you're probably going to have to use rituximab again. So at least until, because I don't think, let me go back up. I don't think rituximab is curative. So if I can't cure them, I have to assume that they're going to relapse at some point. And I worry about giving them rituximab as maintenance when they have no evidence of clinical disease, because if that disease comes back, they might become resistant. So at least today, I do have I have maybe 2 or 3 cases where I've given long-term rituximab maintenance, but it's because I had no other options. They ran out of everything. They failed CAR T cell, and I'm just praying that they stay in remission because I have nothing left to give. Those patients I have given beyond 2 years, but the standard patient, I would stop. Actually, I many times even do less than 2 years. Once I get them into remission, I usually do 3 or 4 more months, but I usually don't go beyond 2 years. And again, the main problem is I worry about resistance.
Does the same thing apply for lenalidomide?
Now, lenalidomide even more, because I feel even stronger here, because lenalidomide, 2 reasons. One to the prior doctor's question about secondary cancers. We know in myeloma that the secondary cancer risk appears to is highest in patients who have had more than 18 months. And so interesting, the relevance trial, we designed 18 months, but we were made to, because the European authorities would not let us give more than 18 months because of the secondary cancer risk that we had seen in myeloma. So here, absolutely, I would not give beyond 18 months. And we don't know what it means. There are no trials, but because of myeloma, no. And then beyond 6 months, the neutropenia rate, I don't know if I've ever published this, but my neutropenia rate went from around 26% to 55% when you go beyond 6 months. So almost everyone beyond 6 months, I had to dose reduce to at least by 5 milligrams. And because in my own experience, if you achieve a CR at 6 months with lenalidomide, most of those patients do really well. I wait and retreat them. So hopefully I'm saying this clearly. No, don't go beyond 18 months of lenalidomide. And if they're in a complete remission, actually, I stop at 6 months because the toxicity starts to increase. So I'm not worried as much about resistance as I worry about long-term side effects with Revlimid.
So my second question regarding the maintenance is for the patients who have received bendamustine rituximab as first-line therapy and or on rituximab maintenance, do you do immunoglobulin levels or CD subsets in patients who are on follow as a routine in your practice?
I actually don't, and maybe I should, but in patients who don't have infections, I usually don't check IgG. Now, again, I usually tell patients if you have more than 4 kind of sinus pulmonary infections in 6 months, I'd start checking IgG. But I actually don't normally, if the patient's asymptomatic, I don't check IgG levels. In the COVID era, maybe we should, but at least in my own practice, after bendamustine, unless they have a clinical symptom to make me suspect hypogammaglobulinemia, I don't check it. Yeah.
Thank you, sir.
Excellent questions. Thank you.
Thank you, Aditya. Dr. Ankit Rayani.
Yeah, thank you, sir. Dr. Nathan, I have a couple of questions regarding the tumor microenvironment that you have mentioned a couple of times.
Sure.
So is it possible to target the tumor cells by PD-L1 or PD-1 inhibitors? Is it possible to decrease the tumor immune evasion by the tumor cells? This is one of the other way.
You guys are so good at it. I mean, there's you should be working at MD Anderson with us. This was a great idea. And what I'm getting at by that is that, so I thought about this. So I was so excited about the lenalidomide, the first trial, as you can imagine, that we wrote, PD-1 plus I think it was, well, first we did PD-1 plus rituximab, then we did PD-1 plus obinutuzumab. And exactly the same thought. And turns out it didn't look much better than rituximab alone. And I still don't know why. We know PD-1 as a single agent does not work for actually I had some I have some slides I could show you there was some data with PD-1 as a single agent in follicular, and the response rate is like 5%. It's not good. And then my colleague Loretta Nastapil, she did a study with pembrolizumab and rituximab, and the response rate looks about the same as rituximab single agent. I don't know why this is, because we know that there you can see PD-L1, PD-1 in follicular, but at least follicular lymphoma is a confusing animal. But
right.
What I'm trying to get, it's a great idea. I always say that to give myself compliments because we thought about the same thing. But the 2 trials we did actually didn't look that great for checkpoints, despite how strong the microenvironment is in follicular.
Right. And on the same topic, there is one more paper from Denmark, I think, where they've suggested increased expression of PD-1 as a risk factor for early or higher risk of transformation from follicular. Do you think we should check for PD-1 expression by this one?
No, I probably wouldn't. I wouldn't waste your stain.
Right.
What I mean is you only have limited amount of stains on your slide. So I don't think that data is mature. We are using, so there are studies with PD-L1 as to use this with transplant. No, it's not CAR T cell.
Okay.
So there, I think, there could be some utility. One thing, interestingly, so James Allison is, I work with him at MD Anderson. James Allison is this, he did all the PD-L1, PD-1 stuff. And he often says PD-L1 is dynamic. We think about it as absolute, but PD-L1 changes, and it could change with the exposure to different drugs. It could just change over time. So again, we think of PD-L1 as a static stain, but it actually probably is changing continuously in the tumor. So I'm not clear that if first off, if we test it today, I don't have anything to do with it. But even then, I think you could have PD-L1, which is positive after rituximab and negative after lenalidomide, or vice versa. So I don't think we know enough about it to warrant you using tissue to stain for it.
Right. And one more topic where I would like your insight is regarding ibrutinib, but not in follicular. In marginal zone lymphoma, though it is approved for the disease, I guess the response rate and the complete response rate, they are not very good. So there are currently trials going on for combination therapy. Any insight on that, ibrutinib plus rituximab therapy?
Yeah, I think this is good. I don't know if they're synergistic. I mean, as I mentioned, we had early on, we were hoping that because you may know ibrutinib and acalabrutinib, they cause this T cell phenotype switch. I think it goes from T1 to T2, so that we thought that it might help augment any CD20. What I'm trying to say is there synergy with the combination, or is it just additive? And I don't know if we know that. We know that obviously rituximab or obinutuzumab has single agent activity in marginal. As you mentioned, ibrutinib, it probably has somewhere around 40 to 50% response rate. Same with acalabrutinib in marginal zone lymphoma. If you're asking me in clinic, what should you do? I do single agent.
Okay.
I don't know if there's true synergy. I mean, I'm getting is if you did single agent, and then when they progress, then you do CD20, it's probably the same. There's no evidence yet that the combination is better than either drug alone. I think maybe let me ask you, which BTK inhibitors are available in India?
So ibrutinib has been available, and right now we have acalabrutinib also available from generic companies.
So there, I think that's a really, I don't know if you're thinking about this question, but which BTK inhibitor? In the United States, both of them are approved for marginal zone. And to me, acalabrutinib definitely looks less toxic. The AFib rate is lower, the bleeding rate is lower. So I think that's for me in the United States, that's a very important question. And the CLL data looks like acala is probably as there are no head-to-heads in marginal zone lymphoma, so we have to use the CLL data. But there, I think acalabrutinib is probably better for marginal zone.
Right, sir.
Side effects.
Right. And one more question regarding R square. So many of the patients, they don't tolerate 20 mg per day of Lenalidomide. So where do we sacrifice? Number of days or the dose?
Dose, for sure.
Dose. Yeah,
absolutely dose. So we the immunomodulatory effect probably works at a dose much lower than 20. In fact, it works as low as 5 milligrams. So the 20 milligram, this is an example of how we design drugs, because it's probably not always correct. We use a phase 1 and we go up to the MTD. So when we hit 25 milligrams with lenalidomide, we saw hypercalcemia, we saw neutropenia. That's why we picked 20. But in the lab, the dose actually works well below 20. We saw immunomodulatory effects at 10 milligrams, 5 milligrams. So you may not need 20. Again, we only used 20 because 25 was too toxic. So what I'm getting at is I have a very low threshold to drop the dose. In patients who have rash, they have low thrombocytopenia. I quickly drop to 15 milligrams or 10 milligrams, same schedule, 21 days on, 7 days off.
Right, sir. Thank you so much for your insights. They were really informative.
That's a really good question, because I definitely still try to do 21 days.
Right.
I should talk about this more, but I dose reduce. The wind changes, I dose reduce. I think 20 is probably too high.
Okay, thank you, sir.
Okay, Dr. Akanksha.
Thank you, sir, for the very comprehensive talk. So I have a question regarding the use of obinutuzumab. Do you have any particular subset of patients where you would prefer using obinutuzumab frontline as compared to rituximab?
Yeah, Again, not really. No. In patients who are rituximab naive, or sorry, CD20 naive, I don't think it matters. There is, I think I told you, 3 years, there was about a 7% improvement in progression-free survival with obinutuzumab. But that was balanced against slightly higher infections and more infusion reactions with obinutuzumab, and no benefit in overall survival. So this is in the randomized trial. So again, you get a little bit improvement in progression-free survival, but it's a little bit more toxic and no difference in long-term outcome. So because of that, I think rituximab is probably as good. And it's funny, even though the United States, even though you had a phase 3 trial, which was positive with obinutuzumab, most people did not change, which is very unusual. You had a positive phase 3, but the field did not switch to obinutuzumab immediately. And I think this is, again, because there was a little bit more toxicity, and long-term, there was no difference. And now you have subcutaneous rituximab, you have generic rituximab. So because of the cost, because of the delivery, we don't see a lot of uptake with obinutuzumab in frontline. Now that's the flip in the relapsed. In relapsed, if patients have had prior Rituxan, I think absolutely you should think about obinutuzumab. Yeah, but in the frontline, I think either one is fine. And if one costs less, I leave that to your decision. But you may. I don't want to get political, but if you have 2 drugs and they work the same and one costs less, then yeah.
And so my second question is regarding the feasibility of using MRD in follicular lymphoma patients, and like monitoring at least especially the patients who are on maintenance, just to predict an early relapse. Yeah. So what are your comments on that?
Yeah, so you guys are making me feel terrible, because this is another area where academics have failed. So we do not have a good MRD marker for follicular. We tried to use BCL2, but it's not very good. It's not seen in everyone. You can have patients who are BCL2 positive who stay in remission, and patients who are BCL2 negative who still relapse. We tried to use like immunoglobulin heavy chain. We've looked at the problem is that in follicular, because it's such a slow growing disease, there's not a lot of circulating DNA. And so in the blood, we've had a hard time developing any MRD marker, because the tumors doesn't proliferate enough to create one. We've talked about using PET as a way to check for MRD, right? That looked okay. In the Prima trial, they looked at PET, even if you're CR by CT, if there's anything on PET. But the long answer is that we don't have a good MRD marker in follicular, nothing that I would recommend using to pick treatment. We'll see Michael Green and Ari Melnick and Cornell, they're trying to develop cell-free DNA assays, but I heard the rumor is that they have not been successful. And probably because of the low proliferation rate in the disease. But yes, I would love to have an MRD marker. But
thank you so much.
Yeah.
Thank you, Akanksha. Dr. Sarthak.
Good evening, sir. Thank you for the wonderful talk. First, I have one question, like what is your current strategy of treatment? Are you using BR versus R-square in upfront setting? So what are the clinical factors which you are thinking and you are using BR in those patients and R-square in some patients, or you are giving R-square as a...
So again, I'm a little bit biased because I develop R-squared. So all of my patients get R-squared. And it's in the United States because MD Anderson in the south of the United States is influential. It's interesting, if you look at the southern United States, most people get R-squared. If you look at eastern United States, most people get bendamustine. So I think of what I'm saying is that tells me that they're both very similar. And so the practice patterns are usually influenced by familiarity with the drug. So people that have trained in Houston, R squared is our standard frontline. We don't use BR in frontline. The only time we would use chemo in frontline is if we suspect transformation. I don't put this in my lecture because this is really because my preference, and I like the drug. And I acknowledge that I'm clearly conflicted because of my experience. BR, I think, is a great regimen. I can tell you in my own practice, I have sports athletes who I have treated who have continued playing sports because lenalidomide has been, so they can tolerate lenalidomide. They don't need an IV. There's no infusion reaction. So I just, there's no nausea. Most of my patients have done really well with lenalidomide. I do have to dose reduce if they develop cytopenias. But for me, if it was my brother, there's no question which I would do, because side effects are so much better with lenalidomide than they are with bendamustine. I hope I answered your question. I'm not saying bendamustine is wrong. It's a great option. I have many people I respect who use bendamustine, but we use really only lenalidomide in the front line at MD Anderson. Clinical factors, I don't think there's any clinical factors that can make you choose one or the other. As I mentioned, shockingly, the survival and the remission rates are identical. And this was a 1,000-patient trial. And we looked at subsets of patients, bulk, age, sex, LDH, FLIPI, they were the same. So it didn't appear there was any subset of patients in the randomized trial that did better with one or the other. They were almost the same in every single subset. So to me, they're equal with regards to efficacy.
Thank you, sir. One more question, sir. If a patient has previously used either R square or BR as a first-line treatment, and then he has a relapse in the form of high-grade transformation at like 12 months or 18 months. So is there data for CHOP with either rituximab versus obinutuzumab, because he has used rituximab in the past?
Yeah, I think the first part of your question is so it's about the length of the length from the prior Rituxan. So 18 months is on the fence. If it's less than 12 months, absolutely switch to obinutuzumab. 18 months, I probably would switch. In the United States, sometimes we have a hard time getting insurance approval unless they progress early. But I probably would switch to R-CHOP with obinutuzumab at 18 months. 2 years, I would use rituximab again.
Okay.
Yeah.
Okay.
Thank you, sir. Dr. Ria?
That was an excellent lecture. And I think most of my questions have already been answered. Just a couple of questions, sir. I have a patient with follicular lymphoma and refractory chylomicrosis. This patient has got R squared 3 cycles already, but the chylomicrosis is still there. So what do you recommend, sir, in this patient? Should I change the line of treatment? PET CT has been done, the lymph nodes have regressed, but the ascites still remains. So should we change the line of treatment or just continue with supportive treatment?
So you have scans?
Yes. The lymph nodes have regressed completely, but the ascites is still there.
I would keep going.
We've done a flow. Yeah.
Go ahead.
So it is still follicular lymphoma there. So should we change the line of therapy, or should
it's 3 cycles?
3 cycles of R square.
I would keep going. So I've had some patients, I haven't seen ascites as much, but I've had, for example, pleural effusions from follicular. And interestingly, they take longer to clear up. Everything can become negative. I've had one patient who took a year. So they got treatment, the PET was negative, everything was clear, the nodes were normal, but it took a year for the effusions to disappear. And so I'm not sure why this, so I'd see patients again who clinically have no evidence of residual lymphoma, but the effusions take a lot longer than the disease to go away. So I think as long as everything else is shrinking, and in only 3 months, I would absolutely continue. Don't worry. I think you're okay.
Yeah. So do you recommend only 6 cycles of R square, or should I put her
So
in
with
some
this patient, it's a little funny. So I think if you go to 6 cycles, if the scans are clear, but the effusion is still positive for lymphoma, I would keep going up to 12 cycles. So as long as you still have active disease in the effusion or the ascites, I would keep using it.
Understood. One more question. I have a patient who presented with as a DLBCL. SUE max was around 25-30. Got 6 cycles of R-CHOP. Post that, there is a residual lymph node. SUE max is around 7 to 12. This lymph node is in the mediastinum. It is 3 to 4 centimeters. So we biopsied it, turned out to be follicular. So again, a composite lymphoma like the case that was presented, but the other way around. So do we treat that, or do we just keep it as it is and just monitor?
3 centimeters.
3 centimeters.
So here's an area where I would actually do rituximab maintenance. Let's assume that the R-CHOP has cured the patient's large cell.
Right.
So hopefully, right? So everything's clear, the SUV is low, right? And so surprisingly, in the Prima trial, which was R-CHOP, let's forget about large cell. We're going to say that's cured. In the Prima study, there was a significant, I want to say it's like 20-30% of patients who were only in a partial remission with R-CHOP. Half of them converted to CR if you added maintenance. So this is actually after R-CHOP, there's good evidence of adding maintenance to get rid of that last little bit of disease. This is actually a great case for maintenance rituximab.
Understood. One more question. R square, when you look at upfront, you're not advocating maintenance therapy, but in a patient, when we are using it in a relapse setting, do we continue with maintenance, or do we just stop at 6 cycles?
Yeah, so this is a tough question. The Augment trial was, I believe, 12 cycles. I probably would stop at 6 if they're in a complete remission. If you go beyond 6, drop the dose to 10 milligrams on cycles 6 through 12, again, to avoid the cytopenias. But in my own cases, I stop at 6. The design of these trials, we didn't know. So when we were designing these trials, although they were presented fairly recently, we designed them 10 years ago. And then we were getting data from myeloma about maintenance after transplant. There was data in CLL that patients would benefit from long-term treatment of lenalidomide. But now I think we're beginning to see that 6 months is probably good for most patients. The problem is now all these studies have been published that use 18 months or 12 months. But again, I'm telling you the background. We designed these trials based upon data from other diseases, like myeloma specifically. And so my own gut is, I don't think, especially if you're in a complete remission, stop at 6 cycles.
Thank you so much. You've been very patient with us. Thank you.
No, I love talking about these. It's my wife jokes, it's the only thing I can talk about well, is lymphoma.
We've learned a lot from you today, so thank you so much. Bye.
Thank you. Dr. Alok Shetty.
Good evening, Dr. Nathan. Thank you for the talk. Just some practical questions. Do you do a bone marrow aspiration biopsy routinely in all patients at diagnosis? I mean, other than prognostication and would it change your treatment?
Yeah, this is a great question. I don't. I used to when I started my career, and I found that it actually doesn't change. The only if patients have cytopenia. If patients have cytopenia, you should look, because there could be another reason for cytopenia, MDS, some myelodysplasia. So in patients who have, and I also want to know if they're becoming anemic or not recovering, if it's from the drug or because they're not responding in the marrow. So if they have normal blood counts, I usually don't do a marrow as long as I have scans. Sorry, one exception is if patient has stage 1 disease and I'm going to do radiotherapy, then I will do a marrow, because if they have marrow involvement, I won't radiate. But if they already have stage 3 disease above and below, it's not going to change my treatment if they're marrow positive or marrow negative. I don't do it.
Yeah, and if there's a patient whom you've given bendamustine rituximab and he's been in remission for say 5 years or so,
yeah,
would you re-challenge if they have a relapse and there's no
I wouldn't, not with bendamustine. No, I mean, I've done this a couple times, and I have patients who come into my clinic and, you know, they've had bendamustine like 3 times, but I think there are enough other drugs, lenalidomide. So in the second line, lenalidomide to me that's easy decision, because the data looks so good, and there even maybe a survival benefit for lenalidomide in second line. So in second line, no question, switch from bendamustine to rituximab. In the third line, then it's a little bit tricky. There it depends on how long they lasted. If, again, I know that both in India and the United States, there are patients who don't have insurance. Maybe they can't get a hold of rituximab. So there, I think, you know, if you're looking at palliation, I have had patients where you can give low dose bendamustine, 50 milligrams of bendamustine. This is just if you have a patient who doesn't have insurance, maybe is elderly. You could do a couple doses just to control the disease. Kind of like like Dr. Agarwal and I used to do with old Cytoxan back in the day when we had nothing else. We would give low dose Cytoxan intermittently for lymphoma. But outside of that case, I think I would not repeat bendamustine.
Okay, and my last question, I mean, why is it that venetoclax has not had some activity in spite of this being a BCL?
I will send you, so I'll send you I actually wrote an editorial in Blood about this. So BCL2 obviously is the mutation that we see in most cases. The current thought is that although BCL2 is required for that initial hit, in follicular, when they develop the subsequent mutations, they lose dependence on BCL2. So what happens is there are other pro-survival signals that actually begin to become stronger than BCL2. So even when you inhibit BCL2, it's not enough to kill the lymphoma. We've thought about maybe we need to use BCL2 early in treatment, because once the disease becomes heterogeneous, it loses these survival signals. But it appears, there's now a randomized trial of bendamustine rituximab plus or minus venetoclax. No benefit of BCL2 in that setting. So again, the current thought is that it's because the disease is driven by so many other genetic hits that BCL2 is no longer important. It is important for the initial event, but after that, it's not dependent on BCL2. That's the theory. Again, I'd be happy to send you. I wrote a big article about why it doesn't work, but the summary is we don't know. We think it's a genetic heterogeneity of the disease. It was another disappointment. Follicular lymphoma drug development is littered with drugs that don't work. Pembrolizumab, ibrutinib, venetoclax, all these drugs that work in every other lymphoma except for follicular. But yeah.
Thank you so much.
Yeah, we again, the short answer is probably too heterogeneous.
Thank you, Alok. Dr. Ankit.
Professor, Dr. Fowler, I'm sorry to have your time second time.
No,
it's a case and it may be long, so just stop me if you feel. It's a 70-year gentleman who has come with a relapse of disease. Earlier diagnosis was 2020 and it was marginal zone lymphoma, stage 3 disease. And he was treated with 6 cycles of bendamustine rituximab at that time, and he was in CR. This time around 1 month back only, he was supposed to be operated for hernia, and peripheral the CBC count was done, which was showing blood counts, which was showing the lymphocytosis. So he was sent to us for clearance, and this was the first time that we were seeing the patient. Earlier treatment was done at some other center. So to our surprise, peripheral smear was showing very large abnormal looking lymphocytes with a high nucleocytoplasmic ratio with nucleoli, cleaved nuclei, and majority, more than 50% of the white cells were these abnormal cells. So I was thinking that definitely this patient has transformed. The patient himself does not have any symptoms, did not have any symptoms regarding B symptoms, no history of fever, weight loss, no pressure symptoms, no local signs also. But USG was showing presence of abdominal lymphadenopathy. And we did a repeat biopsy, which was suggestive of follicular lymphoma. Earlier diagnosis was marginal zone lymphoma. So we got those slides as well and reviewed them. So it was also showing follicular lymphoma. The earlier diagnosis was misdiagnosed, and we were about to start him on ibrutinib, considering a relapse MZL. But now we were in a fix because it's a leukemic presentation of follicular lymphoma. And after searching, I got an article by Dr. Professor Barbara Ben suggesting showing presence of abnormal lymphocytes with cleaved nuclei in the follicular lymphoma setting. It was a leukemic presentation of follicular lymphoma in a relapse setting. Earlier diagnosis was also follicular lymphoma. So my question is, the patient is asymptomatic, but he has a leukemic presentation. So whether we should wait or we should treat this patient. He's also age is 70 years. He's also received BR initially.
Okay.
Right.
So only BR, right? And have you looked at MIC? Do you know if the patient has MIC?
MIC was low. Sorry, expression was not there. CMIC.
Okay.
And the Ki67 was low. Sorry. And we did a PET CT also, which was showing a SUV of maximum SUV of 8, not more than that.
Is the patient healthy otherwise?
Yes, he is healthy otherwise. He's absolutely asymptomatic right now.
I see. And between BR and now, how much time?
Less than 2 years. More than 18 months, but less than 2 years. It was in July 2020. Started and ended 6 months later.
Oh, that's a hard case. So, I mean, you have lots of I mean, you could try a BTK inhibitor because think about it, there's no downside. It's so well tolerated. I know what I said about BTK and follicular, but this is probably coming from a common progenitor.
Right.
So you could try semaglutide, acalab, I don't care, some BTK inhibitor.
So it is the patient is asymptomatic, we have time, and we can judge by peripheral smear only whether it is responding or BTK inhibitor, whether it is working.
To me, the question is like, at what point do you use something like R-CHOP?
Right.
So I don't know. We see these cases, these rare cases of non-transformed follicular and non-transformed follicular with leukemic phase. And I've had a couple of these cases that actually respond very well to things like lenalidomide, to low-grade lymphomas, low-grade lymphoma treatment. But on the flip side, you did BR and he progressed within 2 years, which is, not so great. I think that the only thing different is this case is this prior marginal zone presentation. What you could do, the good news is because you can measure disease in the blood. You could try BTK inhibitor and just do this for about 3 months. And then you'll know. And then if the patient is not responding within 3 months, then you switch to either R-squared or R-CHOP. And I would make that decision on what the patient looks like. If in those 3 months, if the nodes are doubling in size, things are looking much worse, I go R-CHOP. If it's still percolating along, then I would do R-squared.
Okay. And my first question is whether this patient needs treatment or not. He is asymptomatic, other than leukemic presence.
What's the white count?
It's 38,000 per square cubic millimeter.
Yeah. And how about the other counts? They're normal?
Anemia, no thrombocytopenia, only normal range. LDH is also normal range.
what does the patient want to do? Do they want to do treatment?
They are very apprehensive because they've already been to other center and they've been suggested therapy. So
I think you could start some. I mean, I think leukemic phase is a reason to start.
Right.
It's part of the criteria to start treatment. So I think you could start a BTK inhibitor. There's very little downside because it's so well tolerated.
Right.
And you could use this as a test to see how they respond. The question, also would be, do you add a rituximab to it? I would do BTK inhibitor alone because you're not going to know what's working. If you do Rituxan only and it works, you're not going to know which of the drugs. So I would start with BTK only.
Yes, sir. We can start with at least BTK and then see the response in 3 months.
Yeah.
Okay. I have one more question, case, but I can come back later on.
That's okay.
I think there are 2 more questions remaining, sir.
Dr. Vishwadeep.
Hello, good evening, sir. It was a nice presentation. I have one practical issue. There's one patient who had stage 4 follicular, young patient, 30-year-old male, who presented with a neck mass. It's a subcutaneous mass over the back of the neck, around 5 to 6 centimeters in size. And there is also lymphadenopathy above and below diaphragm. So, and there is on further workup, it came out to be follicular lymphoma. And he has systemic disease involving nodes above below diaphragm, bone marrow, liver, and spleen. But according to Guelph, there is no other criteria to start treatment. So should this subcutaneous mass, and we did IHC on both, the nodes also is suggestive of follicular, and like BCL2 is highly strong and 10 is also strong. So it's mostly systemic disease with subcutaneous deposits rather than node. So would it warrant treatment, or we can just wait and watch in this patient? And if we treat, do we treat it differently, like BR versus RCHOP, or just R squared?
Yeah, so these cutaneous masses, do they bother the patient?
It's quite huge.
Yeah, I would treat
5, 6.
Yeah, treat him. Yeah, for sure. Then I would treat him, and BR R squared same. I think they both work again similar. I wouldn't treat him differently because of subcutaneous disease. And it's interesting. He had nodes also, or only subcutaneous?
Yes, sir. Also systemic disease also.
Yeah, I'm saying because we do see these cases where it's only cutaneous. I treat them the same, but it's a little bit unusual to have cutaneous and nodes. It's usually one or the other. But again, if he's got a 5 centimeter cutaneous mass, that's enough to treat for sure for me.
I was also wondering, if it had been only the subcutaneous, cutaneous disease, cutaneous follicular variant, so then would it be different?
Yeah, so here, this is why I was asking. It somewhat depends on the patient. I've had some patients that have it on the face or somewhere, and then they're very concerned because so in the trials where they looked at watch and wait versus early treatment, statistically there was no difference in survival. So you can look at that 2 ways. One is that early treatment doesn't hurt. It does not so starting treatment doesn't help, but it also means it doesn't hurt. So if you start treatment now, it doesn't mean that it's not going to work later. So if the patient has anxiety, stress, because the family is like, oh my God, what is this on you? Or for example, I have an actress and she had it here and she's always has to push her hair. And it just began to bother. So I treated her even though it was only 1.5 centimeters because it gave her anxiety. So when I'm getting cutaneous lesions, you can watch them. I use the same criteria as with Guelph. If they're bulky, then I start treatment. But I also treat patients if they're non-bulky, if it's causing anxiety, if it's cosmetic, really.
And usually follicular lymphoma is bulky disease, so people have large nodes in the iliac region, and usually have edema over both the legs. So when you start Revlimid, do you like properly anticoagulate or just give aspirin or
Yeah,
something
so
like
this
that?
is a good question. In patients, I've seen that in patients that have abdominal disease, they have a higher risk of clot. So in patients with abdominal, so I usually in the first cycle, I give them low dose aspirin, 81 milligrams of aspirin. In patients who have bulky disease in the abdomen, depending on their risk factors, if they're diabetic, they have other risk factors, disease, I actually will sometimes give them Lovenox for the first cycle. Usually by the second cycle, this begins to decrease. But in this patient you're describing, if they have edema, then they probably already have some partial venous obstruction. So they are at very, very high risk for clot. So here, absolutely, they need some anticoagulation. That could just be aspirin for at least the first 2 cycles until the nodes begin to shrink. But if they've got other risk factors, prior history of clot, history of stroke, maybe the uncontrolled diabetes, then I would even maybe add Lovenox and oxyparin for the first 1 or 2 cycles, but at least aspirin for sure. Yes.
And do you have any experience of retroperitoneal fibrosis in a patient with follicular lymphoma who had bulky disease in the abdomen?
I have seen that, yeah. Especially if they present with a lot of disease. The PET becomes negative, but then they have this fibrotic mass. I haven't really seen many complications of this, meaning hydronephrosis. I have had a couple patients who have had bulky disease and they continue to have intermittent bowel obstruction because of fibrosis and mainly in mesenteric nodes. But usually it's not symptomatic. So I ignore it when I'm getting it. So they have this retroperitoneal fibrosis, but as long as they're not having any issues, I don't care. You have to explain to the patient because you get these CAT scans and they keep showing it. But as long as they don't have symptoms, it's okay, I think.
Thank you. That's all. Thank you so much. Thank you, sir.
Yeah, my pleasure.
Dr. Rizwan.
Good evening, sir. Thank you so much for a wonderful talk and clearing a lot of our concepts. I just have a small question that is, because in India, we see a lot of lymphomas presenting at a younger age, even myeloma patients present younger. So we have a few patients aged in their 30s, early 30s, getting diagnosed with follicular lymphoma. So we also have few patients who by the age of 45 years have exhausted all the available 3 major lines of therapy, R-Benda, R-CHOP, R-LEN. So in those cases, how do you go about treating younger patients? Do you treat them differently than the older patients, or do you continue to treat them in the same approach, or do you consolidate with different approaches? Because we don't have party here, we don't have bites here, we don't have tazemetostat here, so that's why.
Yeah, so I think those are two different cases. One is the case of a patient that presents early, untreated. Interestingly, I tend to do less treatment in younger patients. I actually have 19-year-olds and several 20-year-olds that have been diagnosed. And those patients, because I'm not sure what the long-term prognosis is yet, I tend to avoid chemotherapy in those patients. Because I tend to believe that younger people probably have more robust immunity. And so a young patient is actually a great patient to try single agent rituximab, because there is a percentage of patients, maybe as high as 30%, where you can give single agent rituximab and they can get 5-10-year remission. And so in the younger patient, that's the main difference. In a younger patient, I tend to be less aggressive initially. Now, that's very different than the patient you described, where they're 40 and now they've gone through 3 lines of treatment, maybe 4 lines of treatment. That patient is in trouble because if most regimens in the 3rd and 4th line setting, they're associated with only 1 year progression-free survival or less. So a patient who is in the 40s and gone through 3 lines, especially if it's fairly quickly, unfortunately, you should think about transplant. transplant will change in about half of patients can be curative, auto transplant. And if that doesn't work, again, something like allo, you could do trial. But what I'm getting at is in young patients, if in the early stage, I'm less aggressive, but then in the third line, I'm actually more aggressive because it's a very different story. They've got many more years of life, and the treatment options in third or fourth line are not good for follicular. They're short remission durations. So there, I try to intervene with something to change the history. Oh, the other thing I would mention really fast is in the third or fourth line, if they continue to relapse at the single site, I radiate it. I do have some cases in patients that have failed 2 or 3 lines of treatment. Sometimes it looks like there seems to be one nodal group that is always resistant. The other ones go away. I will actually consolidate radiation on that group. And occasionally I'll see people that'll be cured. So I usually don't recommend radiation in the relapse setting, except for that one example where you have somebody that's continuously relapsing in short order. If you can radiate it, and that's still an old but effective option.
Do you use salvage based on the standard high dose intensive like DAP or ICE, or do you have a different kind of salvage before transplant?
So before transplant, yeah, that's a good question. So I don't know why, but I've been underwhelmed with ICE in follicular. So what I found really works well is fractionated Cytoxan. And sometimes I do it without the adriamycin. Just fractionated Cytoxan with dexamethasone is very effective in follicular. Sometimes Gemox. But I don't know if this has ever been published, but my own experience with follicular is rice has been not that effective. And I don't know why, but it's at least for my practice.
Thank you, sir. Thank you so much.
My pleasure.
Anjit?
And
yes, sir, thank you. So, Dr. Pablo, I have one more case to discuss. It's a long case again. So, lady, 40 years, gynecologist by profession, and presented initially with generalized lymphadenopathy with signs of dryness of mouth and other mucosal areas. So we did a biopsy, which was non-specific at that time, reactive lymphadenopathy, and the patient was diagnosed as Sjogren syndrome and received rituximab with steroid. Rituximab total 4 doses, weekly interval by rheumatologist, and total 4 doses, 1 gram fixed dose. So this was done in 2019, and within 1 year, patient was still on dexamethasone on and off as per the symptoms. But within 1 year, she had neck mass, and biopsy was done, which was showing high-grade lymphoma, sort of DLBCL islands with a background of low-grade lymphoma. So composite lymphoma, and along with that, there were other masses in RE system as well as in soft tissue. So high-grade stage 4 disease. And patient was otherwise well, in the sense able to take intensive therapy. So we planned with our rituximab with dose adjusted epoch. And after 2 cycles, the PET was in remission, and so we continued with 4 more. And at the end of 6th therapy, we again did a PET scan. Patient was asymptomatic, but PET scan is negative. And the question is whether we should continue with rituximab maintenance for this particular patient, or whether we should go for autologous.
So actually, I would stop everything now. I wouldn't do either. So patient, it sounds like rituximab only with steroid, got some type of large cell lymphoma, maybe could be almost like a PTLD like from a year of steroids. Epoch for 6, now in a remission, correct?
Correct, right.
Yeah. So the good news is that these patients traditionally actually do quite well if they have a transformation, have never had R-CHOP, only retux. So she's chemo naive.
Right.
So her odds of a long-term remission for large cell are actually good. I mean, they're probably 60-80% chance of achieving a long-term remission for her large cell lymphoma.
Right.
Follicular, she's still at risk for relapse. She has a history of, interesting what you say about Sjogren's. I have so many cases of Sjogren's in my clinic. All I see is follicular. It's very, very common to have Sjogren's and follicular. How is her Sjogren's? Is it controlled?
Right now it is controlled. Right now it's under control. But
Because
maybe because
sometimes-
of intensive therapy.
Yeah, I would just watch her right now with no treatment. But I do have patients where I have used maintenance therapy if they have active Sjogren's, because it controls her Sjogren's and it works for follicular.
So that was the intent behind giving rituximab maintenance, because the patient had high-grade transformation at the time of presentation within 2 years of first diagnosis of Sjogren. Because Sjogren, like you said, follicular lymphoma is common, but then a patient having a high-grade transformation within 2 years, it's a caveat.
Yeah, but they only had rituximab only. I mean, as long as they've never had anything else, I would stop after epoch and just watch closely.
Right, sir. Sure.
Yeah.
Thank you so much, sir. You spent 2.5 hours with us.
No, I love it. I like talking.
Patiently answered so many questions. It was such a learning exercise for everyone, not only those who are present here, but a huge number of audience as well. So many questions in the question box also. Many of them you have already answered, so I will not take your more time. Thank you so much, sir.
My pleasure. On the question, on the chat, I put the link to the BCL2 editorial if anybody wants something boring to read about BCL2.
2020 blood. Yes. Wonderful.
Yeah.
Wonderful. Thank you, sir. Thank you.
Thank you, guys.
Thank you.
Please stay safe. Have a wonderful holiday.
Right. Bye-bye.